Okay, let's unpack this. Welcome to the Deep Dive, where we cut through the noise and get straight to the insights. Today, we're embarking on, well, a really crucial journey, a comprehensive exploration into Down syndrome. This deep dive is designed especially for medical professionals and students, particularly those of you, preparing for challenging exams like the DNB Practical. But we'll also distill key insights for anyone with a deep interest in understanding this condition. Our mission is to transform a complex stack of sources, scientific papers, clinical guidelines like the IAP recommendations, and cutting-edge research into a clear, concise, and hopefully incredibly informative resource. We'll cover everything from the fundamental genetics to the latest management protocols, and we'll even arm you with some exam-style questions later on.
What's truly striking here is that while Down syndrome remains the most common genomic disorder causing intellectual disability, our scientific understanding of its nuances and, crucially, the quality of life for individuals with DS, well, it's evolved dramatically. We'll trace this evolution, focusing on the latest scientific advancements and, importantly, the practical recommendations for care.
So whether you're a medical student, a seasoned clinician, or just someone with a profound curiosity about human genetics and health, prepare for a deep dive packed with aha moments and, surprising facts that will leave you well-informed and ready to tackle any question thrown your way. Let's get started. To truly understand Down syndrome, we have to go back to its origins, literally, to its genetic blueprint. Down syndrome, or DS, is the most common genomic disorder leading to intellectual disability. It's caused by what we call trisomy of Homo sapiens chromosome 21, often abbreviated as HSA21. This basically means there's an extra third copy of this particular chromosome in every cell instead of the usual two. It's this additional genetic material that leads to the myriad of clinical features and manifestations we observe.
That's right. And while the syndrome itself was first clinically described by Dr. John Langdon Down way back in 1866, hence the name, the truly groundbreaking discovery, the link to this supernumerary chromosome 21 didn't come until much, much later in 1959. That finding was a pivotal moment for genetic medicine. It shifted our focus from just, observational clinical descriptions to understanding the underlying genetic cause. And that paved the way for modern diagnostics and research.
And since then, the progress has been, immense, hasn't it? We've moved beyond just recognizing the clinical picture to delving into the molecular pathophysiology, understanding what's happening at a cellular, even subcellular level, and perhaps most importantly, vastly improving the management and support available for individuals with DS, enhancing their lives in really profound ways.
Definitely. When we look at the epidemiology, something particularly noteworthy is that the prevalence of DS is actually increasing globally. But it's not simply because more babies are being born with the condition. It's largely due to significant improvements in childhood survival rates, which is frankly a remarkable testament to modern medical care and comprehensive support. For instance, in the USA, the population prevalence of DS increased substantially. I think it went from approximately 50,000 individuals in 1950 to around 212,000 in 2013.
That's a huge leap, more than quadrupling the population. And this progress is mirrored in life expectancy too, right?
Oh, absolutely.
For individuals with DS in the USA, the estimated mean life expectancy dramatically rose from, was it a mere 26 years in 1950?
Yes, around 26 years.
To 53 years in 2010, with a median of 58 years. That's truly incredible. It speaks volumes about how far we've come in medical care and, societal understanding.
It absolutely does. However, it's also important to note that while survival has improved, the number of live births with DS is influenced by a complex interplay of factors. These include shifts in maternal age distribution as women increasingly have children later in life.
Right.
And significantly, the uptake of prenatal screening and the option of elective terminations. For example, in 2013 in the USA, an estimated 3,400 DS-related elective terminations resulted in about a 33% reduction in live births with DS that year. This percentage can vary quite widely by country. Some European regions reported reductions as high as 54% to 66% between 2010 and 2015. And China saw, I believe, a 55% reduction between 2003 and 2011.
It's quite interesting, though, that studies from places like England and Wales, Australia, and parts of Europe show that even as maternal age is increasing, the widespread uptake in prenatal screening has actually led to stable or even slightly decreasing prevalence in live births with DS since the 1990s in many areas. This really highlights the direct impact of screening programs on birth rates, even as the underlying biological risk factors might be shifting.
Exactly. Now, let's dive deeper into the genetic core itself. When we talk about the extra chromosome 21, it typically falls into one of a few categories. The vast majority, around 95% of individuals with DS, have what's called free trisomy 21. This results from an error in cell division, specifically non-disjunction during meiosis. Meiosis, is the special type of cell division that produces egg and sperm cells, each with half the usual number of chromosomes. Non-disjunction just means the chromosomes fail to separate properly during that process.
So where do these errors usually happen in that intricate process of forming egg and sperm? Is it more on the maternal or paternal side?
Predominantly, these errors occur in maternal meiosis. That's the first stage of egg cell formation. That accounts for about 66% of cases. Another 21% happen in maternal meiosis 2, the second stage. Paternal meiotic errors occurring during sperm formation are less common, contributing maybe around 8% of cases. And then mitotic errors, which happen after conception in the developing embryo, account for about 5% of cases.
And what about the other smaller percentage of cases? I've heard the term translocation associated with Down syndrome. How does that work?
Right. Approximately 5% of cases involve what we call translocations. This is where a segment of chromosome 21, or sometimes the entire chromosome, attaches itself to another chromosome. The most common types are T1421 or T2121. These are particularly crucial because they can have significant implications for recurrence risk in families. If a parent carries a balanced translocation, their risk of having another child with DS is much higher, and that requires really specialized genetic counseling.
Okay, that makes sense. And mosaicism, that sounds like a different kind of genetic picture altogether.
Yes, mosaicism occurs in about 2% of individuals with DS. In these cases, the individual has a mix of cells throughout their body. Some cells have the trisomy 21, while others are euploid, meaning they have a normal set of chromosomes. This mixture can lead to a wider range of phenotypic expression, as the proportion of trisomic cells can vary across different tissues. Then there's partial trisomy 21, which is quite rare. Here, only a segment of chromosome 21 is triplicated, not the entire chromosome. The symptoms in these individuals vary significantly depending on the specific segment that has been duplicated.
Okay, so we've established that an extra chromosome 21 is the root cause. But what exactly does that do at a cellular level? This isn't just about a physical presence, right? What happens inside the cell when that extra genetic material is there? This is where the molecular deep dive gets particularly compelling, I think.
Exactly. The presence of an extra chromosome 21 means that over 200 protein-coding genes located on HSA21 are triplicated. The simplest and most direct explanation for many of the clinical manifestations we see is what's known as the gene dosage effect.
So if I'm understanding correctly, the core issue is that with 3 copies, the cell essentially gets an overdose of these gene products.
That's it.
And that's what triggers a cascade of problems across different systems.
You've got it. This increased dosage means more gene product is being made than is needed. This can have direct effects and then cascade into numerous downstream consequences, fundamentally impacting cellular homeostasis, the cell's delicate balance across all bodily systems. What's truly insightful here is the example of the APP gene.
Ah, yes, the Alzheimer's link.
Exactly. Having an extra copy of APP, which is located on HSA21, directly increases susceptibility to early-onset Alzheimer's disease in individuals with DS. Think about that one extra gene and a significantly higher risk for a debilitating condition. The exciting part. Studies in mouse models have shown that by reducing APP back to normal levels, some of these cognitive effects can be alleviated. That points towards potential future therapeutic strategies, which is quite hopeful.
That's a powerful illustration. So it's not just the direct overexpression of those 200-plus genes, but how that ripples through the entire genome, altering other genes too.
Precisely. Studies show that not only are most HSA21 genes overexpressed, though interestingly, not all of them are, which is another fascinating area of research, but the expression of many non-HSA21 genes located on other chromosomes is also significantly altered. This suggests a widespread perturbation or disruption of downstream transcription and signaling networks. It creates a really complex picture of gene expression dysregulation across the entire genome. We also see tissue-specific patterns. For instance, the interferon response, part of our immune system, is highly upregulated in trisomy 21 fibroblasts and lymphoblastoid cells. This overactivity is thought to be due to increased expression of 4 specific interferon receptor genes, IFNAR1, IFNAR2, INGR2, and IL-10RB, that are themselves located on HSA21. So that indicates a very specific and impactful molecular pathway being overactive.
Right. Beyond just gene expression levels, our sources mention epigenetic changes. Can you explain what that means in this context and why it's relevant for Down syndrome?
That's a vital point, and it brings us to a crucial area of research. Epigenetics refers to changes in gene activity that don't involve alterations to the underlying DNA sequence itself. Instead, these are modifications that affect how genes are read and expressed.
So it's like the software controlling the hardware of the genome.
That's a very good analogy.
And when we talk about methylation, what does that actually do?
Right. Trisomy 21 can alter both regional and global methylation patterns, often with a bias towards hypermethylation, particularly in brain samples. To simplify, methylation is like a chemical tag on the DNA that tells the cell whether to turn a gene on or off, or, how strongly to express it. Several key genes on HSA21, like SLC19A1, GART, CBS, and DNMT3L, are directly involved in these methylation pathways or in a related process called 1-carbon metabolism, which is central to DNA methylation. Overexpression of these genes can lead to widespread transepigenetic changes across the entire genome, fundamentally altering how other genes are regulated.
And histones, too. Those are the proteins DNA wraps around. How are they affected?
Yes, histones are also involved. Think of DNA like a very long string, and histones as spools around which that string is wrapped. How tightly or loosely the DNA is wrapped around these histones affects whether genes can be accessed and read. DYRK1A, another overexpressed gene on HSA21, promotes histone decetylation. This modification can affect chromatin remodeling, how tightly the DNA is packed, and subsequently lead to neuronal gene dysregulation, contributing to some of the neural phenotypic changes associated with DS. A key question that emerges here is, how do these intricate changes in gene expression and epigenetic regulation precisely sculpt the diverse and complex Down syndrome phenotype? It's a key area of ongoing research.
Fascinating stuff. And what about mitochondria?
Yes. Another critical area of impact from trisomy 21 is mitochondrial function. Mitochondria are often called the cell's powerhouses. Trisomy 21 cells and organs consistently show indicators of mitochondrial dysfunction. That means these powerhouses aren't working optimally. This includes things like reduced ATP production, which is the cell's energy currency, decreased respiratory capacity, and impaired mitochondrial membrane potential, all crucial for their proper functioning.
So essentially, the cell's powerhouses aren't working optimally, leading to an energy crisis and cellular stress.
Exactly. This perturbed energy metabolism and oxidative stress, an imbalance between free radicals and antioxidants, could significantly increase the susceptibility of individuals with DS to a wide range of conditions, including intellectual disability and notably Alzheimer's disease. We find that several HSA21 genes, such as NRIP1, SU03, DYRK1A, RCN1, SOD1, APP, and CBS, are directly or indirectly implicated in mitochondrial function. Their triplication likely contributes to this observed dysfunction.
Okay, so how do we study such complex interactions and the roles of individual genes in a condition that affects so many systems? Animal models must be absolutely key to bridging that gap between genes and observable effects.
Absolutely. Animal models, especially mouse models, have been instrumental in advancing DS research. Two prominent examples are the TS65DN mouse, which carries a partial trisomy of mouse chromosome 16 that is orthologous, meaning it evolved from the same ancestral gene as its human counterpart to a segment of HSA21. And another is the TC1 mouse, which actually contains a freely segregating human chromosome 21. These models allow us to study the effects of gene triplication in a living system.
But I imagine it's not a perfect replication, given that Down syndrome is such a uniquely human condition.
Yeah.
What are some of the limitations we need to keep in mind?
That's a crucial consideration, yeah. DS is indeed uniquely human, and animal models cannot perfectly replicate it. There are inherent differences in gene content and expression regulation between human and mouse chromosomes. For instance, the TC1 model, while carrying a human chromosome 21, often results in mosaicism. That means the extra human chromosome is spontaneously lost in many cells, leading to a mix of trisomic and euploid cells. Also, some mouse models are trisomic for genes not even orthologous to HSA21, which can complicate interpretation.
Right. Still, even with those limitations, these models must offer really valuable insights into specific mechanisms and potential pathways.
Indeed. They've shown that many DS features, like cerebellar hypoplasia, midface retrusion, AD-type histopathology, intellectual impairment, and congenital heart defects, are present to varying extents. They've been crucial in helping identify specific genes with major effects. Like we mentioned, reducing APP copy number back to 2 in TS65DN mice significantly improved learning deficits, indicating APP's critical contribution to cognitive deficits. And surprisingly, these models also faithfully replicate the lower incidence of solid tumors, but increased leukemia risks seen in humans with DS. This provides a powerful tool for studying cancer biology in this specific population.
Now that we understand the what's and how of Down syndrome at the genetic and molecular level, let's talk about the who and when specifically. Who is at risk and how we detect it early.
Okay. Well, advanced maternal age at conception is indeed a major well-known risk factor for trisomy 21. This risk is strongly linked to non-disjunction errors occurring during the meiotic divisions that form oocytes, the egg cells. As women age, the cellular machinery involved in meiosis can become, let's say, less efficient, increasing the likelihood of these errors. These can occur in both maternal meiosis saphir and meiosis II. The risk increases significantly as maternal age advances.
Is it solely about maternal age, though, or are there other genetic predispositions that might make some women more susceptible to these meiotic errors?
That's a perceptive question, and it brings us to an active area of research. There's a clear rationale for examining genetic variants that might predispose to meiotic non-disjunction. Studies using candidate gene analysis and even genome-wide association studies have identified specific variants in genes coding for synaptomal complex components. These are proteins critical for chromosome pairing and segregation during meiosis. For instance, variants in SYCE2 have shown an association specifically with meiosis I errors, while variants in SYCP2 seem to be associated with meiosis II errors. So it's not a simple picture. The risk factors are heterogeneous based on the specific type of meiotic error that occurs.
And what about environmental factors? Those are often so much harder to pin down and study definitively.
Environmental factors certainly influence risk, but they are indeed challenging to identify due to inherent problems with, defining exposure, dosage, timing. Our sources mention several factors that have been investigated, though causality is complex to establish. These include tobacco use, folic acid supplementation, oral contraceptive use, and even maternal socioeconomic status, which interestingly has been associated only with maternal meiosis II errors.
I recall something about occupational exposure playing a role as well.
Yes, some job categories involving exposure to certain solvents in the work environment have been linked to specific meiotic errors. Furthermore, there's growing evidence that endocrine-disrupting chemicals, such as bisphenol A or BPA, can affect meiosis and increase the prevalence of aneuploidy, potentially even with transgenerational effects, meaning effects passed down to future generations. This is a complex area requiring more extensive research, and it's important to remember that different types of meiotic errors might have different susceptibilities to specific environmental exposures.
Okay, so for pregnant women, identifying pregnancies at high risk for DS is a routine part of antenatal care in many developed countries. What are the main screening approaches used?
The overarching goal of screening is to identify those high-risk pregnancies, thereby limiting the need for invasive diagnostic procedures, which, while generally safe, do carry a small risk of miscarriage. Historically, maternal serum biochemical analytes, basically, substances found in the mother's blood, were key for this.
Like the double marker in the first trimester or the quad screen in the second? I remember those terms.
Precisely. First trimester combined screening, typically performed between 11 and 13 weeks, involves assessing maternal age, measuring fetal neutral translucency, NT, via ultrasound that's a fluid pouch behind the baby's neck, and measuring maternal serum beta-human chorionic gonadotropin, HCG, and pregnancy-associated plasma protein A, PPPA. This combination offers detection rates of around 85–95%, with about a 5% false positive rate. For second trimester screening, usually done between 15 and 22 weeks, the quad screen typically measures maternal age, alpha-fetoprotein, AFP, free BOC HCG, unconjugated estriol, UE3, and inhibin A. This yields detection rates around 70–75% with the same 5% false positive rate. Accurate gestational dating by ultrasonography is absolutely crucial for interpreting these results correctly.
And ultrasonography alone, what role does that play in screening? Can it pick things up?
Prenatal ultrasonography can identify a range of abnormalities associated with DS, things like increased NT and absent nasal bone, tricuspid valve regurgitation, and certain soft markers like echogenic bowel, where the fetal bowel appears unusually bright on ultrasound, or pilotasis, which is a mild swelling of the kidney's drainage system. However, it's critically important to remember no fetal anatomical finding is diagnostic of DS on its own.
Okay, that's key.
Many neonates with DS can have apparently normal prenatal sonograms. It's a screening tool, not a definitive diagnosis.
Then came NIPS, or NIPT. How has that changed the game for screening? It feels like it was a huge leap forward.
Non-invasive prenatal screening, NIPS, which sequences cell-free placental DNA found circulating in maternal plasma, has truly revolutionized screening since its clinical availability around 2011. It's significantly more sensitive and specific than traditional methods. It boasts a detection rate of around 99% and a remarkably low false positive rate of less than 0.1% for trisomy 21.
Wow.
It can also be performed much earlier, as early as 10 weeks gestation.
That sounds incredibly accurate, almost like a diagnostic test itself.
It is remarkably accurate for a screening test, which is why it's becoming the primary screen for high-risk women in some countries, and even for all pregnant women, regardless of their initial risk, in places like Belgium and the Netherlands. However, it's essential to emphasize that it is still a screening test, not diagnostic. A high-risk NIPS result still requires confirmation through invasive prenatal diagnostic testing.
Right, right. So what does this all mean for families? What are the benefits of obtaining a prenatal diagnosis if the screening comes back high risk?
Prenatal diagnosis, when confirmed, can offer several important benefits. These include psychological preparation for the parents, providing an opportunity for parental education about Down syndrome, facilitating meetings with pediatric subspecialists ahead of delivery, and allowing for planning of delivery at a hospital equipped to care for the baby's specific needs. This can help ensure that the mother and baby can remain in the same hospital together, offering, a smoother start.
Okay. So if screening suggests an increased risk, what are the diagnostic tests?
Right, then prenatal diagnostic testing is recommended to confirm the diagnosis. This involves either chorionic villus sampling, CVS, typically performed between 11 and 13 weeks of gestation, or amniocentesis, which is usually done after 16 weeks.
And what are the risks associated with these invasive procedures? Families often have concerns about them.
The risk of procedure-related pregnancy loss is actually quite low, particularly when performed by experienced providers. It's around 0.11% for CVS and between 0.1 to 0.3% for amniocentesis. These figures highlight the safety improvements over time. But the small risk is precisely why screening precedes diagnostic testing.
Okay, once the fetal sample is obtained, what kind of analysis is done to confirm the diagnosis?
Confirmatory testing involves either conventional karyotyping or chromosomal microarray, CMA. Karyotyping, which looks at the overall structure and number of chromosomes, has a turnaround time of maybe 10-14 days and detects larger chromosomal anomalies, typically bigger than 5-10 megabases. CMA is generally more expensive but faster, with results available in around 7 days and offers a much higher resolution. It can detect smaller genetic changes that karyotyping might miss. Additionally, rapid aneuploidy detection techniques like FI fluorescence in situ hybridization or qFPCR quantitative fluorescent polymerase chain reaction can provide preliminary results in 24-48 hours. However, it's crucial to understand that these rapid tests only indicate the presence of an extra chromosome 21. They don't determine its origin, like it's due to a translocation, which has important implications for recurrence risk.
Got it. What about after the child is born? Is postnatal genetic testing still necessary even if there was a prenatal diagnosis?
Yes, even if a diagnosis is made prenatally, postnatal karyotyping is still routinely done for definitive confirmation. This helps to determine the exact type of DS specifically, if it's due to a translocation, which is vital for accurate genetic counseling for the family and for guiding anticipatory management and long-term care.
Okay. And speaking of counseling, let's talk about recurrence risk.
Understanding recurrence risk is absolutely vital for genetic counseling, especially when families plan future pregnancies. For free trisomy 21, which, as we discussed, is the most common form, the recurrence risk in subsequent pregnancies is relatively low, around 0.5 to 0.7%. This risk can slightly increase with maternal age, particularly after 40.
What about translocations, which you mentioned have different implications? How does that affect recurrence risk?
Right. In cases involving parental Robertsonian translocations, which typically involve chromosomes 13, 14, 15, 21, or 22, the recurrence risk is significantly higher. If the mother is a carrier of such a translocation, the chance of having another child with DS can be up to 10-15%. If the father is the carrier, the risk is typically lower, less than 1%, possibly due to poor survival of sperm carrying the extra chromosome. And, crucially, in rare cases of a 21-21 translocation that is not de novo, meaning it's inherited from a parent, the recurrence risk is 100%.
Wow, 100%.
Yes. Therefore, formal counseling by a clinical geneticist or genetic counselor counselor, is strongly recommended for all families, regardless of the type of trisomy 21, to fully understand these risks.
Absolutely. Okay, Down syndrome affects multiple bodily systems, and individuals present with a distinct set of clinical features and potential complications. Let's do a deep dive, system by system. This is incredibly important for our DNB exam listeners, and frankly, for a complete understanding for everyone.
Indeed. Starting with common physical findings, individuals with DS often exhibit short stature, generalized muscle hypotonia, meaning low muscle tone, making them seem a bit floppy.
Right.
A small brachycephalic head, which means a flattened back of the head. Epicanthal folds the fold of skin over the inner corner of the eye. A flat nasal bridge and occiput, small mouth and ears, and upward slanting palpebral fissures, which is the opening between the eyelids. Other characteristic features can include brush-field spots in the iris of the eyes, excessive skin at the nape of the neck, a single transverse palmar crease, often called a simian crease, a short fifth finger with clonodactyly, which is an inward curving, and a wide space between the first and second toes, sometimes with a deep plantar groove.
And intellectually, what is the typical neurodevelopmental profile that's important to understand?
DS is the most common genetic cause of intellectual disability. Most individuals are classified as having mild to moderate disability, typically with an IQ ranging from 35 to 70. Their cognitive profile often shows relative strengths in visual learning and social functioning, but may present with weaknesses in areas like expressive language, verbal working memory, and episodic memory. Recognizing these strengths and challenges is really key to tailoring educational and therapeutic support effectively.
Are there other neurodevelopmental challenges or co-occurring conditions that are frequently observed?
Yes, co-occurring conditions are quite common, which is why a holistic approach is vital. For example, autism spectrum disorder, ASD, is seen in about 10–15% of individuals with DS.
That's quite high.
It is. And attention deficit hyperactivity disorder, ADHD, in about 6%. Management of these conditions should generally follow standard treatments, though responses to stimulant medication in ADHD might be less marked in individuals with intellectual disability. Early screening and intervention for these are critical for optimal development and quality of life.
One of the most common and serious complications, often identified early, is congenital heart defects. This is a life-critical area.
Absolutely. Congenital heart defects, or CHDs, occur in a significant proportion of individuals with DS, affecting 40 to 60% of them.
40 to 60%.
Yes, it's very common. The most frequent types are atrioventricular septal defects, AVSDs, which is a hole between all four heart chambers, accounting for about 42% of all CHDs in this population. Then ventricular septal defects, VSDs, holes between the lower chambers at 22%, and atrial septal defects, ASDs, holes between the upper chambers at 16%.
So routine screening here is vital, both prenatally and postnatally, for immediate intervention if needed.
Absolutely. Fetal echocardiography, an ultrasound of the baby's heart, is highly recommended during pregnancy to identify potential heart defects early. Postnatally, a cardiology examination with echocardiography should be performed within the first month after birth to establish the infant cardiac status, ideally by 6 weeks of age. Early detection can literally be life-saving.
And how are these defects typically managed? Is it different from the general population?
Management is generally the same as for the general population, primarily involving surgical repair. Notably, our sources indicate that the mortality rate after surgery in children with DS is equal to or even lower than that in the general population, which is very reassuring.
That's good to hear.
It is. It's crucial not to delay correction for large shunt lesions like AVSDs, VSDs, or patent ductus arteriosus, PDA. That's an open connection between two major blood vessels leading from the heart, to prevent the rapid development of pulmonary vascular disease, which can lead to poorer outcomes. All individuals with DS should also have annual screening throughout life for signs of acquired valve disease and heart failure.
Okay. Thyroid dysfunction seems to be another incredibly frequent issue and one that requires lifelong monitoring. This truly impacts overall health.
Yes, thyroid disorders are very common in children with DS, affecting a substantial 24 to 50% of them.
Wow, up to half.
Yes. Congenital hypothyroidism, meaning hypothyroidism present at birth, is found in about 1% of individuals. And abnormal thyroid function tests are reported in over 50% of neonates.
And the risk actually increases with age, doesn't it? It doesn't just stay static.
It certainly does, particularly for autoimmune-related thyroid dysfunction, which becomes more prevalent as individuals age. Subclinical hypothyroidism, characterized by elevated TSH levels but normal T4 levels, is the most common thyroid abnormality seen. Left untreated, even subclinical hypothyroidism can impact cognitive function and overall well-being.
What's the recommended screening schedule for thyroid function according to those IAP guidelines we mentioned?
According to the IAP, TSH and T4 levels should be obtained postnatally, then again at 6 months, 12 months, and then annually thereafter throughout life.
Annually for life?
Yes, annually. For subclinical hypothyroidism, treatment is generally recommended if TSH remains persistently above 10 MIU/mL, or if the individual exhibits clinical symptoms of hypothyroidism, has a goiter, or if thyroid autoantibodies are present.
Okay. Any other significant endocrine issues that are common besides thyroid problems?
Children with DS often present with short stature, though usually without overt growth hormone deficiency. Low bone mineral density is also common, which can be due to a combination of factors like lower physical activity, maybe less sun exposure, obesity, and associated illnesses like celiac disease, as well as certain medications. In pubertal children, hypergonadotropic hypogonadism, characterized by high LH and FSH levels, is often seen, and puberty can also be delayed sometimes.
Got it. Hearing and vision problems are also quite prevalent and can significantly impact development if not addressed early, especially for communication and learning, right?
Absolutely. Hearing impairment affects over 50% of people with DS.
Over half.
Yes. Conductive hearing loss, often due to chronic otitis media with effusion that's a buildup of fluid behind the eardrum, sometimes called glue ear, is particularly common in young children. This is because of specific craniofacial features like large adenoids, small nasopharynx, and narrow eustachian tubes. Sensorineural hearing loss becomes more common in adulthood.
Early identification and intervention here must be crucial for language development then.
It is, critically so. Neonatal hearing screening is recommended, followed by a full audiological assessment between 6 and 10 months of age, with intervention initiated if needed. Audiological review should then be performed yearly until age 5 and thereafter 2 yearly for life. Management includes regular dewaxing, grommet insertion for persistent otitis media with effusion, and potentially hearing aids or cochlear implants for more severe loss. Sleep studies are also advised due to the high prevalence of obstructive sleep apnea, which can exacerbate hearing and speech issues and impact learning.
Right, sleep apnea is a big one. What about vision? That's another vital sensory system.
Ocular disorders have a really high prevalence, affecting up to 60% of people with DS.
60%.
Yes. Nasolacrimal duct obstruction, where tear ducts are blocked, is seen in 10 to 36% of infants. Refractive errors like nearsightedness or farsightedness are about 10 times more common than in the general population, affecting up to 54% of preschoolers and 50% by age 4. Other common issues include blepharitis, inflammation of the eyelid, in about 30% of children, congenital and developmental cataracts, nystagmus, involuntary eye movements, congenital glaucoma, strabismus, crossed eyes, affecting 25–30%, keratoconus, thinning of the cornea, in up to 15%, and amblyopia, lazy eye, in up to 20%.
Wow, that's a lot to monitor for. Clearly requires careful and regular ophthalmic care to preserve vision and support learning.
It is. An ophthalmological examination should be done at 4–6 weeks of age to exclude congenital glaucoma, cataracts, and other significant abnormalities. Formal reviews should then be repeated at 18 months to 2 years, again at 4 years, and then every 2 years throughout life. Prompt treatment and corrective aids are essential to maximize visual development and prevent long-term complications.
Okay. Hematological issues, particularly transient myeloproliferative disorder, TM, and leukemia, are significant concerns, especially in the early years.
Yes, children with DS have a markedly increased risk of developing acute leukemia compared to children without DS. Transient abnormal myelopoiesis, TAM, sometimes called transient leukemia, is observed in 5 to 30% of individuals with DS before 3 months of age.
How is this identified and managed, and what's its significance for the child's long-term health?
A complete blood count, CBC, and peripheral blood smear examination, PBS, should be performed within 3 days of birth to identify TAM. While TAM usually resolves spontaneously in the first few months of life, it's a critical indicator. It increases the risk of developing myeloid leukemia of DS, MLDS, by 5 years of age, with an estimated 20 to 30% of children with TAM progressing to MLDS.
20 to 30%, that's significant.
It is. Therefore, children with a history of TAM need close monitoring. That means 3 monthly clinical reviews and CBC-PBS until age 2, then 6 monthly until age 4. This early and consistent surveillance is absolutely key.
What about other blood issues? Are they common?
Nutritional anemia is common, especially in developing countries, and can significantly affect cognitive status. So yearly blood counts must be done at least until 5 years of age. Polycythemia, an abnormally high concentration of red blood cells, is also common in the first week of life, affecting about 33% of newborns with DS and may persist for several months.
Got it. Our sources also mention various skin issues, which can be quite varied and sometimes related to other underlying conditions.
That's right. Things like seborrheic dermatitis, xerosis, which is just dry skin, and palmoplantar keratoderma, thickening of skin on palms and soles, occur more frequently in individuals with DS. Dry skin, for instance, predisposes them to irritant and allergic contact dermatitis. Acanthosis nigricans, that darkening and thickening of the skin, is also noted and is often a marker of insulin resistance, frequently associated with obesity.
Oh.
Alopecia areata, patchy hair loss, affects 6 to 10% of individuals with DS and is often associated with other autoimmune conditions like vitiligo and hypothyroidism. Individuals with DS also tend to experience accelerated aging signs, things like early graying and thinning of hair, skin atrophy, early development of wrinkles, and lentigines, which are like freckle-like spots. A thorough cutaneous examination at routine visits is highly recommended to identify and manage these conditions promptly.
Okay. With generalized hypotonia and laxity of ligaments, I'd imagine musculoskeletal issues are quite common and can significantly impact mobility and even safety.
Absolutely. Musculoskeletal problems in DS stem primarily from that central hypotonia, the laxity of ligaments, and excessive joint mobility. The feet, hips, and spine are common areas involved, leading to reduced mobility and a higher risk of injuries.
Atlantoaxial instability sounds particularly serious, given its location in the neck. What are the key points there?
It is a serious concern. Atlantoaxial subluxation, which is a misalignment of the first and second cervical vertebrae, C1 and C2, in the neck, develops in about 1–2% of children with DS. Symptoms like neck pain, weakness, spasticity, gait difficulties, or hyperreflexia, overactive reflexes, warrant immediate evaluation, usually with cervical spine radiography. However, routine screening radiographs are generally not recommended for asymptomatic children, as they don't reliably predict future problems.
Okay, so no routine screening x-rays unless symptomatic.
Correct. Instead, extreme caution with neck positioning during any anesthetic, surgical, or radiographic procedure is strongly advised. Participation in contact sports also significantly increases the risk of spinal cord injury, so that needs careful consideration. Hip and foot examinations should be done in the first year of life, and a hip x-ray should be considered for any child presenting with a limp. Scoliosis screening should also be considered if suggestive findings are present.
Right. Oral health is another area with specific challenges and requires consistent attention, which I imagine can be difficult for parents sometimes.
Yes, certainly. Individuals with DS frequently present with a relatively large and fissured tongue, a small oral cavity, malocclusion, misalignment of teeth, dental agenesis, missing teeth, enamel hypoplasia, defective enamel formation, delayed dentition, increased dental caries, and periodontal disease. It's quite a list.
It is.
The first dental visit is recommended within 6 months of the first tooth eruption or by 1 year of age, and then yearly until age 5 and annually thereafter. Good oral hygiene, including brushing twice daily with a sock toothbrush and fluoride toothpaste and daily flossing, is crucial. Limiting sugar and refined foods is also really important for dental health.
Absolutely. And what about the gut? Gastrointestinal issues can affect overall health and nutrition significantly.
Structural and functional GI disorders are quite common in DS. These can include significant congenital anomalies like esophageal atresia tracheoesophageal fistula, duodenal or jejunal atresia or stenosis, which are blockages in the small intestine, annular pancreas, or ring of pancreatic tissue constricting the duodenum, and erectile anomaly and Hirschsprung disease. Beyond these structural issues, feeding difficulties affecting 31 to 80% of individuals, gastroesophageal reflux, and chronic constipation are also common.
And celiac disease.
Yes, celiac disease, that autoimmune reaction to gluten, is seen in approximately 5% of those with DS. Symptomatic individuals should be screened with tissue transglutaminase IgA, TTG-IgA, and a simultaneous quantitative IgA. That second test is important because an underlying IgA deficiency, which is more common in DS, can render the TTG-IgA test unreliable, leading to a false negative.
Good point. Okay, what about renal and genitourinary health? These are less commonly discussed, but still important for long-term well-being.
Congenital anomalies of the kidney and urinary tract, CACRD, are noted in DS. With increased survival into adulthood, glomerular diseases like IgA nephropathy and focal segmental glomerular sclerosis often appear between the second and third decades of life. And testicular tumors have a significantly higher risk, maybe 6 to 50 times greater than in the general population. So yearly testicular exams are important for male individuals with DS.
Okay. Puberty and sexuality are sensitive but crucial topics for comprehensive care, especially as individuals with DS transition to adolescence and adulthood.
Definitely. Individuals with DS do have intimacy needs and sexual feelings similar to anyone else. While males with DS are often infertile, women with DS have approximately 70% fertility, with a 50% chance of having a child with DS if they conceive.
Okay.
Caregivers should be counseled about pubertal changes, menstrual hygiene, and contraception. And it's vital to have professionals skilled in supporting individuals with DS in these sensitive discussions, ensuring respect and appropriate education.
Finally, mental health. An area that can be complex to diagnose and manage in individuals with intellectual disabilities, given potential communication challenges.
Yes. Individuals with DS have an increased prevalence of behavioral and mental health problems compared to the general population, particularly depressive and anxiety disorders. A small proportion experience what's known as acute regression or Down syndrome disintegrative disorder, typically in adolescence or early adulthood. This involves a sudden loss of skills and independence.
It sounds distressing.
It can be very distressing for families. Diagnosis can be challenging due to intellectual disability and communication difficulties, requiring careful observation and collaboration with caregivers. However, treatment generally aligns with standard clinical guidelines, and individuals with DS often show positive responses to behavioral interventions, psychotropic medication, and psychological therapy.
Okay, now let's turn to the practical side, management and the vital follow-up schedule. This section is particularly important for our DNB students, as we'll be highlighting the Indian Academy of Pediatrics, or IAP, guidelines. While these are critical for exam preparation for all our listeners, the overarching principle here is proactive, lifelong, and comprehensive monitoring.
Exactly. The IAP emphasizes a holistic biopsychosocial strategy for management. This acknowledges not just the biological aspects of health conditions, but also the profound psychological impact on individuals and families, and the crucial social aspects like inclusion, advocacy, and financial support. It moves beyond a purely medical model to a comprehensive social and rights model. The aim is really to empower individuals with DS to lead independent and fulfilling lives.
So it's truly about the whole person, not just the medical condition they happen to have.
Precisely. Regular and repeated counseling of parents is paramount. It should ideally start as soon as DS is suspected, preferably at birth, and continue after confirmation and a full workup. This ongoing support is essential for a sustained management program, guiding families through each developmental stage.
What should that counseling involve to be most effective? And how should professionals approach these often difficult conversations?
It should be positive, accurate, and balanced. It's recommended to refer to DS as a condition, not a disease, giving importance to the person first rather than their diagnosis. Counselors should detail associated conditions, emphasize the need for regular follow-up and early interventional programs, and also highlight the absence of certain conditions if they're not present, providing a realistic but hopeful outlook. Connecting families to local Down syndrome support groups is also invaluable. Peer support can complement professional efforts, offering a community of shared experience which is incredibly helpful.
That sounds like a much better approach. What about perinatal management? What's recommended for monitoring during pregnancy?
Right. Pregnant women carrying a fetus with a confirmed DS diagnosis need regular monitoring and support throughout the perinatal period. There's an increased risk of miscarriage in these pregnancies. Monitoring recommendations suggest that a detailed ultrasonography examination and fetal echocardiography should be performed at 18-20 weeks gestation. Further ultrasounds are recommended at 28-30, 34-36, and 38 weeks to assess for potential complications like upper GI obstruction, fetal hydrops, or intrauterine growth restriction. If any abnormalities are detected, increased fetal surveillance is recommended, and local pediatric teams should be informed so they can be involved in planning postnatal care and treatment, ensuring a seamless transition.
Okay, now for a key takeaway for our DNB students. While the full, detailed IAP follow-up schedule is quite extensive and may be best absorbed visually, we'll outline the critical milestones and areas of focus for each age group here. For those listeners who need the full, detailed checklist for their exams, we'll make sure to provide it as a downloadable resource in our show notes.
You're right. Understanding the structured approach is essential. The IAP provides a very structured, age-wise follow-up schedule designed to be proactive and comprehensive. So, at birth, The immediate focus is on confirming the diagnosis and identifying critical health issues. This involves karyotyping and genetic counseling, a complete blood count, CBC, and peripheral blood smear, PBS, for those hematological issues like TAM, thyroid function tests, TFTs, and crucially, an electrocardiogram, ECG, and echocardiogram to screen for congenital heart defects. A thorough systemic examination is performed, and growth parameters are recorded to be plotted on DS-specific growth charts. An eye examination at 4 through 6 weeks is also essential.
Okay, that's a busy start. What about the first year?
By 6 months, key checks include repeating thyroid function tests, TFTs, and performing a full audiological review to assess hearing development alongside continued growth monitoring. By 1 year, the comprehensive review adds repeating CBC and TFTs, getting a dental opinion to establish early oral care, and performing a hip and foot evaluation for musculoskeletal issues. Ongoing monitoring of growth and development remains crucial.
And into the toddler years.
At 2 years, follow-up includes repeat CBC and TFTs, a full ophthalmologic examination, another audiology review, and a dental review. Testicular examination is also recommended, along with continued growth and developmental monitoring. From 3 to 5 years, the pattern of regular CBC and TFTs continues annually, along with audiology, ophthalmology, and dental reviews every 1 to 2 years depending on age, and annual testicular examinations. Consistent growth and developmental monitoring is paramount, along with reinforcing early intervention therapies.
And as they get into school age?
For children aged 6 to 9 years, the general schedule continues with yearly TFTs, 2 yearly audiology and ophthalmology reviews, and annual dental and testicular examinations. Importantly, this period also emphasizes initiating life skills programs with a special focus on interpersonal relationships, laying the groundwork for greater independence later on.
What about adolescence?
For adolescents aged 10-18 years, follow-up continues similarly to the 6 to 9 years age group, with yearly TFTs and regular audiology, ophthalmology, testicular examinations. During puberty, counseling should specifically address physical and psychological changes, and the need for appropriate gynecologic care in pubescent females should be discussed, including things like contraception and menstrual hygiene.
Got it. And some important general notes our sources emphasize regarding routine health and wellness for children with DS, like vaccinations.
Yes, absolutely. Routine vaccinations should never be skipped. The need for pneumococcal conjugate and polysaccharide vaccines, influenza and varicella vaccines should be particularly stressed due to increased susceptibility to respiratory infections. Furthermore, it's vital that evaluation and investigation should be done more frequently if clinically warranted. Meaning, if symptoms or concerns arise outside the routine schedule, medical attention should be sought promptly. Don't wait for the next scheduled checkup.
Right. Beyond medical checks, early intervention is highlighted as absolutely key for fostering development and helping children reach their full potential.
It is critically important. Physical therapy, coupled with speech stimulation, should ideally start at birth, or at least by 3 months of age. Comprehensive developmental therapy, occupational therapy, behavior therapy, and cognitive therapy are all vital components of support, tailored to individual needs. Ongoing psychological evaluation and support for both the child and the family are continuous needs as they navigate different developmental stages.
Especially with those co-occurring conditions like ADHD and autism, early attention seems even more pressing.
Absolutely. Conditions like ADHD and autistic spectrum disorder can manifest as early as 2-3 years of age and must be addressed promptly with appropriate interventions. Psychiatric support during adolescence for issues like sexuality, anxiety, and depression is also crucial and should not be ignored, ensuring their emotional well-being is prioritized.
Okay. The IAP guidelines also extended recommendations on educational and vocational aspects, emphasizing a broader view of the individual's life and their place in society.
Yes, our sources really stress the importance of inclusive education.
Right.
Precisely. Inclusive education in normal schools is advocated, often with special education facilities as needed to provide tailored support. The recommendation is that children should ideally be enrolled in First Standard by 7 to 8 years, based on their individual intellectual status. Beyond formal schooling, vocational training, tailored to their aptitude, should begin around 15-17 years of age, after completion of school. The guidelines encourage suitable independent vocations, which are preferred over group activities, with the latter reserved for those with more severe intellectual challenges. It's about fostering self-sufficiency.
That makes sense. Finally, the IAP places significant emphasis on the human element. Counseling, how should that be approached?
Yes, they stress that communication with the family should be initiated as soon as the diagnosis is suspected, preferably right at birth. While preliminary confirmation can be made rapidly by FIESH, karyotyping is essential to determine the exact type of DS for full genetic counseling. Families need ample time to understand the child's status. Doubts must be answered patiently and empathetically, and ideally, both parents should be present with a support person for these sensitive discussions.
So what does this all mean for the long-term perspective of counseling, and how does it shape the family's journey?
Well, the counseling should start on a positive, accurate, and balanced note, referring to DS as a condition rather than a disease, and emphasizing the person over the condition. It's crucial to detail associated conditions, but also to highlight the absence of any expected issues, providing a clear picture. The need for sustained interventional therapies must be reinforced, clarifying that no medicine can modify the chromosomal status, but therapies will significantly improve skills and systemic illnesses can be effectively managed. The social issues and rights of individuals with DS should be explained. And connecting families to local Down syndrome support groups is highly recommended, as these groups provide immense practical and emotional help, building a supportive community around them.
That support network sounds invaluable. We touched on preclinical studies earlier. Are there any promising therapeutic interventions on the horizon based on these molecular insights? It's exciting to think about what the future might hold.
Yes, definitely. It's a very active area of research. Clinical trials are currently exploring pharmaceutical and nutraceutical agents specifically aimed at improving cognition in individuals with DS. Many of these efforts have been directly paved by preclinical observations in mouse models. For example, inhibition of DYRK1A, which is that overexpressed gene involved in brain development,
Right.
maternal dietary choline supplementation, and dosing with vasoactive intestinal peptides like NAP and SAL have all shown postnatal improvements in learning and neurobehavior in TS65DN mice. This kind of targeted research is truly groundbreaking.
And what about specific drug candidates that have made it to human trials? What's the latest there?
Researchers explored inverse agonists of GABA IBI5 receptors, such as RG1662. This compound showed promise in mouse models by restoring long-term potentiation, LTP, which is crucial for learning and memory, and improving cognition, as the reduced LTP in DS models seem to stem from excess GABA-mediated inhibition. Now, while a phase 2 trial for RG1662 didn't ultimately show efficacy, it was a landmark. It demonstrated the pharmaceutical industry's willingness to develop treatments for intellectual disability in DS, which was a huge step forward for the community.
Yeah, just getting that attention is important.
Exactly. Another notable trial used green tea extract containing epigallocatechin-3 gallate, EGCG, which has shown some successful improvements in cognitive outcomes in young adults with DS.
Interesting. What else is being looked at?
Metformin is also being investigated. Preclinical studies revealed it activated the PGC1 pathway, reversing mitochondrial dysfunction in human DS fetal fibroblasts. Given metformin's existing FDA approval for gestational diabetes, its potential use in pregnant women carrying DS fetuses might face fewer regulatory hurdles for clinical trials, which is potentially advantageous. Fluoxetine, a common antidepressant, has also shown promise in mouse models for restoring hippocampal neurogenesis and connectivity, but its use in the first trimester raises concerns about potential congenital malformations. So that needs careful consideration. Epigenin, a natural flavone, is another compound showing potential in reducing oxidative stress and improving some behaviors in mouse models treated prenatally.
So these are still early days for many of these potential therapies, but the hope for targeted treatments based on our molecular understanding is definitely there and growing. It offers a glimpse into future possibilities for care, which is fantastic.
Absolutely. The pace of discovery is accelerating.
It's clear that our understanding and care for individuals with Down syndrome have come such a long way. So what does this all mean for their prognosis and overall quality of life today?
Well, the remarkable increase in life expectancy from around 26 years in 1950 to 58 years in 2010 in the USA is a powerful testament to improved medical care, expanded educational opportunities, and greater societal adaptation. This leads us to a crucial question, really. How can we ensure this extended lifespan is not just longer, but also matched with a high quality of life filled with meaning and independence?
Our sources clearly mention that if adequately supported, many individuals with DS can live fairly independently, which is a fantastic shift in perspective from decades past.
That's right. While stigma and cultural norms can still be barriers in some regions, increasingly, children with DS are educated in mainstream schools, often with additional one-to-one or specific special educational needs support. Many individuals are employed and report high levels of job satisfaction. Some even become successful professionals in various fields, including arts and advocacy. However, it's worth noting that there's still a disparity between those who wish to work and those who find suitable employment. This is often due to things like social care cuts and inadequate workplace adjustments, highlighting areas for continued advocacy.
So the quality of life isn't just about medical health, but also very much about social integration, personal fulfillment, and the ability to participate fully in community life.
Precisely. Proactive screening and early intervention for common conditions like hearing and vision problems, managing obesity, and addressing musculoskeletal issues can significantly reduce their negative impacts and improve overall well-being. This, in turn, enables greater participation in physical activities, community life, and meaningful social interactions, fostering a more independent and fulfilling life journey.
Looking ahead then, what are the key research frontiers?
Despite the remarkable progress in understanding and care, there's currently no treatment for DS based solely on its molecular pathophysiology. Future research is absolutely vital to advance this. Key areas include understanding the precise contribution of genetic variation to phenotypic diversity through large-scale genome sequencing studies, identifying specific functional genomic elements that contribute to the phenotype when triplicated, and using advanced experimental models like induced pluripotent stem cells and sophisticated mouse models to study brain and organ development in unprecedented detail.
This next frontier of research sounds truly exciting for the future. What about cutting-edge techniques that are pushing the boundaries of what we can understand and potentially treat?
Advances in single-cell technologies are particularly exciting. These allow us to study the genome, transcriptome, and protein levels in individual cells. This can potentially unravel the altered developmental pathways in DS at an incredibly granular level. We can look at how chromatin conformation, the way DNA is packed, affects gene expression dysregulation. Furthermore, experimental efforts to directly modify gene expression dysregulation on HSA21 and other chromosomes are being actively explored for novel therapeutic approaches. That offers real hope for targeted interventions down the line.
And for a broader understanding of the real-world impact and evolving needs across the lifespan.
Population-based, longitudinal, large-scale cohort studies are critically needed. These would follow individuals with DS over their lifespan to further understand the spectrum of co-occurring medical conditions, family attitudes, educational achievements, individual experiences, and societal successes. This comprehensive data will be invaluable for informing policy, improving care, and enhancing quality of life for all individuals with Down syndrome, truly making a difference on a larger scale.
We've covered a vast landscape today, from the intricate genetics of trisomy 21 to the comprehensive age-specific IAP guidelines for management. We've seen how medical advancements and a holistic biopsychosocial approach are transforming the lives of individuals with Down syndrome, fostering greater health, independence, and inclusion.
As we conclude, a key question for all of us, I think, is how do we continue to build on this knowledge and apply it practically in our daily lives and professional practice? The journey of understanding Down syndrome is ongoing, filled with scientific challenges, but also immense hope for individuals and their families.
And for those of you preparing for your DNB practical exams, the details we've explored today, from the specific screening timelines to the nuances of clinical presentation and management, especially those IAP guidelines, are absolutely critical. We hope this deep dive has been a valuable resource. Before we sign off, we want to give you a tool to help solidify this knowledge. As promised, here are 15 short answer style questions. They're designed to be of moderate to severe difficulty to help you prepare for your OSCE examination. Take a moment, pause if you need to, and test your understanding. Remember, the detailed IAP guidelines are available in our show notes for those specific checklists. Okay, here are the questions. 1. Describe the 3 main genetic causes of Down syndrome and their respective frequencies. 2. Outline the IAP recommendations for prenatal screening for Down syndrome, including specific tests and preferred timing. 3. A newborn presents with hypotonia, epicanthic folds, and a single palmar crease. What initial genetic testing would you recommend and why, according to IAP guidelines? 4.
List 4 common congenital heart defects seen in children with Down syndrome and state the IAP recommendation for cardiac screening in newborns. 5. Detail the IAP follow-up schedule for thyroid function tests from birth through 5 years of age for a child with Down syndrome. 6. Discuss the prevalence and clinical significance of transient abnormal myelopoiesis, TAM, in neonates with Down syndrome, including IAP monitoring recommendations. 7. Enumerate 3 common eye problems and 2 common hearing problems observed in children with Down syndrome. What are the IAP recommendations for screening these conditions up to age 5 years? 8. Explain the gene dosage effect in the context of Down syndrome, providing an example of a specific gene and its phenotypic consequence. 9. A 4-year-old child with Down syndrome is suspected of having obstructive sleep apnea. What diagnostic procedure is recommended by IAP guidelines, and why is this condition clinically significant? 10. Describe the IAP recommendations for early interventional programs for children with Down syndrome, specifying the age at which these should ideally begin. 11.
What are the primary risk factors for Alzheimer's disease in individuals with Down syndrome, and what baseline assessment is recommended for early detection? 12. Discuss the IAP's biopsychosocial strategy for managing children with Down syndrome, outlining its core components. 13. A 7-year-old child with Down syndrome is on a gluten-containing diet, but presents with persistent diarrhea and slow growth. What specific diagnostic test is recommended by IAP guidelines for suspected celiac disease, and why is simultaneous quantitative IgA important? 14. Outline the IAP recommendations for sexual education and management of menstrual cycles in adolescents with Down syndrome. 15. Beyond medical care, what are 2 key IAP recommendations regarding the educational and vocational aspects for children and adolescents with Down syndrome? Thank you for joining us on this deep dive. Keep learning, keep questioning, and keep making a difference. We'll be back soon with another deep dive into a fascinating topic. Until then, stay curious.